that's being ignored. Um, and I wonder, I mean, it sort of, again, had a bit of a bad history. Ipi and melanoma was approved based on these couple of large studies, and Ipi and melanoma did great, a disease that really had no positive, no cure, no nothing. And so great results showed up, had to be looked at. In lung cancer, single agent data was negligible. So right away you go to combination. The combination study here by Tom Lynch was randomized with paclitaxel and carboplatin, and they looked at concurrent versus phased. And the answer was they showed some benefit, but it really wasn't all that convincing. And people started to lose interest relatively quickly. And then the stage got taken away. We've got, as we've talked about already, second line and metastatic, everybody can be Taxotere, first line metastatic, chemoimmuno, pembro, and high TPS scores, and then jumping into stage 3 disease, unresectable, immunotherapy is taken off. And everyone sort of looked at this and said, Ipilimumab is just a less effective, more highly toxic drug, and I think enthusiasm waned. But it's not the same. We've all showed this slide many times that ipilimumab is very different than PD-1 inhibitor. Ipilimumab, or CTLA-4, is involved largely on the priming side of things, whereas PD-1 is more involved on the effector side at potentially the peripheral tissue level. Clinically, we look at these and we see that there is a difference. When you look at side effects, toxicity grading, the top is ipilimumab, and everyone had rash, diarrhea, hypophysitis, skin toxicities were interesting. You do the same thing with a PD-1 inhibitor, and with the PD-1 inhibitor, there's that new pulmonary, the little green line that shows up down here. And so it added a new toxicity. Granted, it wasn't a huge amount, but it was a new toxicity, and it's a different kind of toxicity. Most of us can deal with the neutropenia, which isn't here, but you could deal with diarrhea if it's short-lived. But we have great respect for pulmonary toxicity. Patients can die with this. Mouse data. So recently published paper in Cell says that there is a distinct cellular mechanism between anti-CTLA and PD-1 checkpoint blockade. And the point's made here that both PD-1 and CTLA expand specific tumor infiltrating populations of an exhausted phenotype of CD8. And the paper goes on to say that both are really good at making the T cell proliferate within the tumor. It doesn't necessarily have to happen outside. It can happen within the tumor. And then both decrease Tregs, but CTLA seems to do it to a greater degree, and therefore raising the effector to suppressor ratio. CTLA goes one step further, and at least they were able to say that it induces expansion of an ICOS Th1-like CD4 effector population. And the point is CTLA has slightly more function potentially than PD-1 does. And shouldn't completely forget about it. I mean, ipilimumab and melanoma, this is the 10-year follow-up curve. And I mean, 110 years. We don't have any metastatic studies that ever talk about this. And it's 4 doses. You come in, you get your 4 doses, you're gone. So it's something that we just don't deal with in lung cancer. Very, very different model. So so how do you go and pick out, as we discussed earlier, how do you pick out what's the right answer? Who do you go after? Well, there's no great biomarker. The biomarkers that they've been looking at have been absolute lymphocyte count. And down here, you can look at absolute lymphocyte count over time. Again, this is in melanoma data, but you can look at absolute lymphocyte count as a baseline. When you walk in the door, those with higher counts do better. After your first treatment or after your second treatment, so sort of a conditional marker. If you've got high lymphocytes to begin with and they get higher, you're going the right direction. So that's That's more a marker, I guess, potentially of the host. Immune-related events have been predictive to some degree. Those patients who did have toxicities had higher response rates and durable benefit. So there's some marker there. Maybe, again, that's host-related because you had a side effect, you were predisposed. Maybe that's a marker. People have looked at circulating VEGF as a potential marker, but there's been no specific marker that just made everyone stand up and get excited. Um, this is a busy slide, but another paper, again in melanoma, and they looked at host factors. And, geez, I don't know if I can read these, but, oh good, someone can look or read better than me. But what they looked at were some melanoma specific, high LDH, others looked at absolute lymphocyte count, myeloid-derived stem cells, and eosinophils and presence of monocytosis. So this is, again, a host reaction. Not necessarily a biomarker from the tumor, but potentially a host reaction can give us some answers. When you take these 6 markers, so we said there's that 20% of patients that live a long time. When you take all of these, put them together into a bigger model, you can start to pick a group of melanoma patients who are doing okay at 35, 40%, which is kind of striking. They looked at some other markers here. LDH maybe as a tumor marker, or maybe it has some other function I'm not aware of. They looked at CD subsets, MDS, CD4, and others. And they looked at these and showed all of these pretty much had a negative prognostic factor, prognosis. So they said this was at diagnosis, but the argument was, geez, if they're negative at diagnosis, what happens to them over time? Maybe they could either be used as a surrogate marker for efficacy to develop other biomarkers. So again, no biomarkers, kind of a challenge here. We did a little study that was just recently presented, and it was kind of an embarrassing study. We took EGFR ALK patients and we gave them Ipilimumab. It was a phase 1 just to see if the two could be put together. We know that many patients with Tarceva don't actually take the real dose. Most of my patients aren't actually on 150. So the strategy to bring more patients in was give yourself a month or so to get a stable dose, or 2 months or 3 months, but we let them have a few months to find a stable dose, and then you wouldn't be taking them out for intolerance of the Tarceva by itself as a single agent. So we let these patients come on, and they all got Ipilimumab, 4 doses, and they received their targeted therapy. And when the 4 doses were over, they were followed for their targeted therapy until progression. And we defined 2 levels of PFS, or PFS from the start of study when you got your IPI, or from the start, from when you begin your targeted agent. And this was to be an interesting study. It didn't go very well. We ended up with excessive toxicity, and the study got closed early. We only put 14 patients on the study. Originally, we were going to treat 6 patients per arm before we had an expansion cohort. We ended up with 2 of 6 in the first place with grade 3 diarrhea. For this reason, we stopped, held it up for a while, and says, well, maybe 2 of 6 isn't so bad. Let's go to 10 patients. On average, patients got 4 doses of Ipilimumab, but these are the toxicities we finally saw. 4 of 11 EGFR had grade 3 diarrhea, but it was self-limited. Nobody died of this. 1 of 3 of the ALK patients developed grade 3 hypophysitis, long-lasting, but the point is we can fix that. And there were some other toxicities, but the point is people can tolerate this. It's short-lived. PFS was kind of striking, and so we, at this point, we shut the study down. We said how terrible we were, and we kind of hung our heads. But these patients just keep coming back to clinic, and they don't get, and they're still going now, strong at this point. So of the 11 EGFRs, from the time they began the study, this is 18 months, and these patients haven't changed, so that's probably another 4 or 5 months on top of this. And PFS from the beginning of erlotinib was about 25 months. The 3 ALKs, the same thing, 2 years from IPI, a little about 2 years from the beginning of crizotinib. So maybe there's something there. The overall survival is listed here, and we just grouped the 14 patients together. I totally admit these are small numbers, but I mean, these patients are now 40 to 50 months out from the beginning of their targeted therapy. Maybe this is a kinder, easier way of doing it, or maybe it's just small numbers. And so what's the downside? Well, the criticisms that are coming up right now quickly, besides small numbers, are what about, how about the Tatton study? And so basically they tried combining osimertinib with a PD-1 inhibitor, and they ended up with substantial toxicity. In this little study, ILD occurred in 26% of patients at any grade, but they had a 9% grade 3-4 rate of ILD, kind of dangerous. And then in the EGFR naive, they ended up with 64% of patients with some degree of ILD, and 43% had grade 3-4. And so the point here is maybe these don't combine as well, but maybe they combine less well with drugs that have a pneumonitis problem rather than combining with drugs that don't. And this is just the conclusion. So I question whether we gave up on Ipi too early in lung cancer. We could have some sort of a biomarker that subsets it to a smaller population of patients as time goes by. Do we care? Is the Ipi activity going to be combined in Nivo Ipi, so maybe we don't need to pick out those patients? You need a biomarker. Is driver mutated lung cancer a different disease than run-of-the-mill small cell lung cancer? Well, I think it very much is. Different prognosis, different genetics, different therapies, different responses. The study is interesting. Should one go forward with this? Does osimertinib make it irrelevant? And the last part of that slide was just to go and say, small numbers, I apologize for that, but I wonder if there is some hint, should one go forward with this further? And do we have our blinders on? Once we've got a brand new toy in our head, this PD-1 inhibitors, are we just ignoring drugs that may be active like CTLA-4? Especially bothersome when we're looking at drugs that have no proven activity. Thank you.